WYPL TV 18 presents The Power of Sleep, sponsored by Methodist Sleep Disorders Center, dedicated to alleviating the effects of sleep disorders and improving the sleeping lives of our patients. The Methodist Sleep Disorders Center can help you determine if you have a sleep-related breathing disorder. If you believe you or your loved one may have a sleep disorder, consult your physician. More information from the Methodist Sleep Disorders Center can be found online at www.methodisthealth.org/sleep or at 901-683-0044 to determine your best treatment option. Methodist Healthcare. Be treated well.
Hello and welcome to The Power of Sleep. I'm Dr. Merrill Wise. We'll be talking today about the very growing and dynamic field of dental sleep medicine. I'm very, very pleased to introduce our speaker, Dr. Alan Blanton, who is an associate professor at the University of Tennessee College of Dentistry. Dr. Blanton is the director of the Division of Dental Sleep Medicine and Orofacial Pain. Welcome.
Thanks.
Dr. Blanton also serves on the American Academy of Dental Sleep Medicine Board of Directors.
Correct.
Been doing that for about 3 years now. So I mention that because that gives Dr. Blanton a nice overview of where dental sleep medicine is and where it's going across the country. So we're also pleased to have Dr. Neil Aguillard. Dr. Aguillard has been a guest numerous times, and he is a pulmonary medicine, critical care, and sleep medicine specialist with Mid-South Pulmonary. He's also the medical director of the Methodist Healthcare Sleep Disorders Center since its inception in
89, 90.
89 or 90.
Yeah.
So it's there's a lot of continuity of leadership there. So, but thank you for joining us again. One thing that our viewers may or may not know is that the field of sleep medicine is very multidisciplinary and very interdisciplinary, and most physicians who do sleep medicine are either pulmonary specialists or neurologists. A few are ENT specialists or pediatricians or perhaps psychiatrists. There are psychologists who are involved as well. But a very dynamic, growing area of sleep medicine is also dental sleep medicine. And so that's why we're so excited to cover that topic today. I'd like to ask Dr. Blanton first if you would just, as an introduction, give us a brief overview of what is the field of dental sleep medicine.
Well, dental sleep medicine is the area of dentistry that's involved with primarily oral appliance therapy to treat sleep disordered breathing conditions, primarily like obstructive sleep apnea, primary disruptive snoring, and sleep-related bruxism or tooth grinding and clenching.
Okay, all right. Well, I think that helps kind of put our viewers on the same page with what is this field. And so for a person to be a dental sleep medicine specialist, they're first a dentist.
Correct.
And then they take additional training and learn more about sleep and sleep disorders and how the dentist can have impact on that.
Right.
One question I've often wondered about is, can an orthodontist become a dental sleep medicine specialist?
Yeah, there are quite a few orthodontists. In fact, the area of dental sleep medicine and the oral appliance therapy, most of the appliances that we use are some type of a modified orthodontic appliance. So orthodontists were some of the original people involved in the whole field of oral appliance therapy.
And an orthodontist is a specialist who
moves teeth.
Moves the teeth around.
Right.
Okay.
Right.
All right. That's a great way to put it.
Yeah.
Okay. Well, since one of the things we're talking about really for much of this show is a sleep disorder that's called obstructive sleep apnea, I thought we might begin by asking Dr. Aguilar, just tell us what is obstructive sleep apnea? How do patients with this disorder present?
Obstructive sleep apnea is air not getting to the windpipe. And there's something above your voice box that is narrowing partially or completely, and you struggle to breathe or get air down into your chest when you sleep. People who normally have sleep apnea almost invariably snore, and despite spending an adequate amount of time in bed at night, feel a loss of energy and or sleepiness the following day.
So, and of course snoring is a sound, and what makes people snore? What does snoring due to?
Snoring is when air is trying to get through a tube that's too narrow.
Okay.
And invariably snoring is a sound that you make when you inhale.
So it's a vibratory sound.
Right.
So, yeah. Dr. Blanton, with your involvement with dental sleep medicine, what is it that attracted you as a dentist to then become more focused on dental sleep medicine?
Well, about 12 years ago, I was struggling to stay asleep all night. And
this sounds like a story.
yeah, it's a story. Really, I had noticed there was a difficulty in maintaining sleep, and then feeling tired and run down the next day, just not feeling like myself. So I went to my primary care physician and basically said, "Isn't there a drug you can give me to make me sleep all night?" And fortunately for me, he said, "Well, before we do that, let's get a sleep study and see what's going on," because I just thought it was insomnia. Turned out I had moderate sleep apnea, obstructive sleep apnea, and the physician that diagnosed me asked me at that time, knowing I was a dentist, that if I knew about oral appliance therapy. And 12 years ago, I really didn't know anything about oral appliance therapy. So he sent me some information. That's when I kind of started my journey of studying. It interested me. You get kind of burned out after 20, 25 years of doing the same thing every day. So it was something new to look into, and got interested in it. Met a lot of great people across the country that are doing this, and got interested and started, So
it was really a new chapter in your career, it sounds like, yeah. Well, in terms of the treatment options for obstructive sleep apnea, I'd like to turn back to Dr. Aguillard. So we know that sleep apnea is a spectrum. Of course, there are borderline forms, mild, moderate, severe, and very severe forms of obstructive sleep apnea. But in general, what are the therapy options available to a patient today with sleep apnea?
The most common is CPAP, which is a device that either fits on your nose or nose and mouth and applies positive pressure when you sleep, and it keeps whatever is collapsing above the opening of your windpipe from collapsing. Obviously, oral appliances have a place in what we do. Ear, nose, throat physicians will see patients, and if there's something anatomically blocking air, that can be fixed or removed. Now we have the option of actually some devices that are used to stimulate the muscles above the opening of your windpipe to keep them taut or keep them tight to keep the tissue open. Okay,
so that's a very nice overview. And in essence, what we want the viewer to know is that there's really a menu of options. And so often the general public or even some physicians may think that, if one has obstructive sleep apnea, that therefore means they must be treated with CPAP.
Not necessarily.
And of course, it's not true at all. There are options. The advent of dental sleep medicine, of course, has then given us a great new set of options. And just tell us a little bit about what is an oral appliance and how might it work in obstructive sleep apnea?
Well, oral appliances are basically devices that fit on the upper and lower teeth and have some mechanism that allows us to move the lower jaw forward slightly, hold it in a little forward position. But the main function is it stabilizes that lower jaw, because a lot of times in sleep, as we get into the deeper stages of sleep, we start to lose the muscle tone, and when we get into REM sleep, we lose all the tone of the large muscles, including the muscles in the back of the throat that support the airway. So, may I do this?
Please do.
That's what I show my patients. So when we do that and we sleep, everything tends to want to drift back to the airway, and this is where the obstruction most of the time will occur. So when we use CPAP, we're blowing pressurized room air past that obstruction, much like blowing air into a deflated balloon to keep the airway open. And with oral appliances, what we're trying to do, again, is lift everything forward a little bit and then stabilize it. And with oral appliances, we're trying to prevent everything from collapsing to begin with. Right. Okay. Because the tongue is attached to the lower jaw. The side walls of the airway are attached to the lower jaw. So when you pull tension on those muscle attachments and tissue attachments, we can a lot of times support that. And oral appliances are much more beneficial in mild to moderate sleep apnea. In severe cases, we always want to try to get the patient on continuous positive airway pressure therapy or CPAP therapy. But if they fail at that, then oral appliance therapy could be considered.
Even if it's severe.
Even with severe. If we can get a patient back to mild to moderate levels, we decrease the risk of some bad cardiovascular event occurring.
Well, and I think also the combination therapy, we all know that being overweight or obese, some of that weight is in the neck, the tongue, the soft tissues. And I think one of the most exciting things about this option is that if we link an oral appliance with an active, successful weight loss program, we really have another set of patients who could benefit.
And we also do it too a lot of times in order to decrease the pressure that's needed to open up the airway on the more severe patients.
Dr. Blanton, what would be the usual sequence if a patient they've been to their sleep medicine physician, they've been given a diagnosis of, let's say, mild to moderate sleep apnea, and for whatever reason, there are certain patients who struggle to use CPAP, and that's probably for another show, but for whatever reason, they really were not successful with CPAP, and so they come to see you, and I'm assuming that they would begin with just a conversation with you. And what would happen?
Generally, at the patients usually enter our clinic in one of two primary ways. Either they are self-referred, or their bed partner or spouse gets them into the clinic because they've read something or seen something about oral appliance therapy, and they know that their loved one is not utilizing CPAP therapy effectively, or they're referred by St. Methodist Sleep Disorder Center or one of the other sleep disorder centers or sleep physicians to us because the patient is not complying well with CPAP, or it may just be the better option for the patient. So when the patient comes in, our primary deal is to figure out, are they a candidate for oral appliance therapy? So one of the major things is they've got to have enough healthy supportive teeth, because all of these appliances, attach right to the teeth, and so we've got to have
reasonably healthy
teeth and enough of them to support the appliance. And then the second thing we're looking at is, do they have an adequate range of motion from their jaw all the way back to all the way forward like a bulldog? And that range can be anywhere from, say, 6-7 millimeters up to generally up to 15 millimeters. The people that we tend to have the most success with have an average range of 10 to 15 millimeters of movement.
Of the jaw.
Right.
Okay. All right.
So those are the primary things we're looking at, and whether or not the patient is, going to be able to tolerate having that appliance in their mouth all night.
Okay.
Alan, do y'all routinely X-ray to help you do a determination, or is it strictly an exam?
Initially, in the initial consultation, a lot of patients will already have X-rays, from their dentist of record. If they don't, we'll take an X-ray. Generally, I don't end up taking any radiographs or X-rays on patients until we actually do the workup. Over the years, you can pretty much look at people and know if you've got. Well, you can definitely know if people have problems just by clinically looking at them.
If the decision is to move ahead, then what would happen next?
We do a very comprehensive, complete exam on all the structures that could be affected by wearing an oral appliance long term. Oral appliances can cause problems in a small percentage of patients, tooth movement, bite relationship changes. So that's one thing that it's real critical, that if we put a patient in an oral appliance, that we follow them very closely. Initially, after the first 3 months where we're working with the patient to get them adjusted and accommodated to the appliance, we want to see the patient back 6 months after we insert the appliance, and then again 6 months after that, or a year after we insert the appliance, and then on a yearly basis. If we're going to have any kind of bite changes or tooth movement, it's going to usually occur in that first year. And then we have to make a decision, is this something we want to continue to do, which most patients do, because for most patients, the tooth movement or jaw bite relationship changes are not horrible. And we're looking at a much better quality of life for a lot of patients that are, breathing better at night and sleeping better.
So you would do a thorough evaluation. You would select which appliance type you're going to work with. Then you actually make the appliance.
Well, I don't.
Yes, someone does.
The lab does.
They do it under your guidance.
Right. And we turn in a prescription for what we want, and then the gifted people at the dental labs are the ones that make the appliances for us.
Then the appliance is made. Patient comes back. We try the appliance in, insert it, deliver it. If there's any minor adjustment we need to make at that point, we do. We send the patient on their way and give them a couple of weeks to do what we call accommodate to the appliance. And our mission there, our purpose there, is to give them an opportunity to get used to wearing the appliance. I mean, most of these people have not had anything in their mouth. For 40, 50 years, and now we've got a big hunk of acrylic in there, and it takes a moment to get used to wearing that. But generally, most everybody can accommodate to wearing the appliance, within a few nights. Right. And so then you'll follow them at a specified interval. And then is there a phase in which you then start adjusting the appliance?
Well, yeah. Generally, there's about a 2 to 3 month period that we're working with the patient. And it depends. It's all dependent on the patient. We may need to see them back 5 times during that 3 month period. We may only need to see them back a couple of times. We're checking basically how their symptoms are doing. Has their snoring been reduced or eliminated? Are they sleeping better, not having the awakenings at night? Do they feel better in the morning? What does their bed partner or spouse say about the changes they're noticing in their sleep? So we're looking at all these subjective symptoms and the positive changes there. And then at that point, we would want to get the patient back with their sleep physician for an evaluation and a determination of what to do at that point.
Dr. Aguilar, what would that involve, from your standpoint? Is it an individualized thing as to whether you would repeat a sleep study?
Yeah, it would be. A, how severe was it before they were treated? B, how bad are their symptoms? And, if it was severe and Alan feels pretty comfortable that he's there, we'd probably do some sort of diagnostic testing to show that, like I said, we may not be hitting a home run, but we may get to third base. It might be mild. They're not symptomatic and their oxygen level's not low, and it's not a health risk. And the bed partner's not complaining of snoring. So it kind of depends, on the individual.
I think what I'm hearing too is that this is a great example of the communication and collaboration that really needs to be there. I mean, it's a team approach. And
when we're dependent on him deciding, I'm there. We have to rely on someone who's trained as to his judgment that this thing has been adjusted and this is...
And that the patient's dental health is still good. In other words, the body relationships are still good and that kind of thing. Dr. Blanton, if a patient is going to have any complications to oral appliance therapy, is it going to tend to occur early on?
Generally, it does. We're going to notice things pretty quickly. And again, that's why the protocol that the Academy of Dental Sleep Medicine, in conjunction with the American Academy of Sleep Medicine, our protocol is, there are 2 major things in there. Obstructive sleep apnea needs to be diagnosed by a trained and qualified physician who's trained in sleep to diagnose the condition. Then once the patient is turned over to us to manage that with an oral appliance, then it's very incumbent on our part to communicate back with that physician as to where we are and what we're able to do, and then to follow that patient, because if there are going to be tooth changes or bite position changes, within that first year we're going to know it, and then we've got to have the conversation with the patient. Are you willing to continue down this road of therapy? And almost always the patients are. And again, the kind of changes that we see that we would consider more permanent changes are fairly rare. They're not a real common, but they do occur.
So that's why it's important to follow.
And we don't know who it's going to be. So that's why we have to follow everybody.
So there's no, in terms of like 5, 10, 15 years down the road, there's no lurking secret problem that's likely to show up if the patient was doing fine early on?
I wouldn't think so.
You would think
not
it would
in
present.
my experience or that of my colleagues.
Yeah, and you've had patients now that you've followed for years and years. So, okay. One question that patients often ask me is, well, how often am I going to have to get a new appliance? What's the story on that?
Well, the American Academy of Dental Sleep Medicine came out with a paper a couple of years ago that stated that an effective oral appliance should maintain its effectiveness and its integrity as an appliance for at least 3 to 5 years. I've had appliances that have lasted longer than that, but they are pieces of dental plastic and some type of metal attachment or plastic attachment. So depending on how rough the patient is with the appliance when they're wearing it and how well they take care and maintain the appliance, they can last 5 years or longer. But our experience has been that most insurance companies will reimburse for oral appliance therapy after about 3 years on most policies.
Okay, well, that's good to know. One thing that I'm curious about, and I'm learning right along, as I talk with you guys and through my own practice, but there are some patients who ultimately do best with dual therapy, where they need CPAP plus an oral appliance. And I know that's not a common occurrence, but Dr. Aguilar, have you?
Well, Alan had mentioned this earlier. You may have made the apnea better, and it still needs something else. Well, if you do CPAP with an oral appliance, the pressure that works is much, much lower, and the higher the pressure is, the more uncomfortable it is. So you've ended up using two things, but it would have been a much more unpleasant experience if you had not had an oral appliance.
That's right, yeah. So there really is an opportunity for dual therapy that can make a real difference for the patient. So, and again, just to summarize, that an oral appliance, in essence, is advancing the mandible, the jaw, and to some extent the tongue. Would that be fair to say?
Well, yeah, you're bringing the jaw. Yeah, you're bringing the base of the tongue forward because it's attached to the lower jaw as well. Right. We find that if I could bring everybody's jaw 4 inches forward, I could keep everybody's airway open, but that's not practical. Right. What we find is, just from a practical standpoint, is more about stabilizing the jaw. I don't tend to start people off bringing them as far forward as I used to. The more forward you bring them, the more opportunity you have for side effects to become an issue. So a lot of us, as we do this more, over the years, we find that maybe we don't need to advance quite as far as we used to. It's more about stabilizing the lower jaw.
Okay. Well, it's amazingly similar to the concept of titration,
right?
With CPAP, with the patient with obstructive sleep apnea being treated with CPAP. We want to find that perfect pressure, which is enough to keep the airway open, but not so much that the patient can't tolerate it. And it sounds very
well. And as part of that, the definition of an effective oral appliance. All oral appliances that we use are custom made to fit a specific patient's teeth and jaws, and they're all adjustable. They all have some mechanism for adjustment, so we can advance or move the jaw back or forth where during the management and the treatment time.
That reminds me to mention, just our time is running short, but the approach where the individual orders something online, usually by dialing a 1-800 number, it's shipped to them and they boil it and sort of fit it to their teeth. I mean, after hearing you describe the relatively detailed process of evaluating who's appropriate and then tailoring a device to that person and then following them, these are completely two separate processes. And from your standpoint, I mean, do these devices where they ship you something and you boil it and self-fit it, do those offer any help?
Well, it's interesting. There have been several studies that have been done, research studies have been done that show that the most effective oral appliances obviously are ones that are custom made and fitted for that patient, and you go through that whole process of evaluating the patient and managing them. The boil and bite appliances, the ones that are more like a football mouth guard type of situation, they can have some effectiveness. The problem is that they tend to be very bulky. They're not as retentive or don't attach to the teeth as well as we can do with a custom-made appliance, and so they're not as effective.
Right.
It boils down to basically they're not as effective.
Okay, very good. I want to ask just briefly, we're nearing the end of the show, but I wanted to also cover the problem known as sleep bruxism. And tell us briefly, what is that?
Sleep bruxism is it's classified as a repetitive masticatory muscle activity, which the masticatory muscles are the muscles involved in chewing, moving the lower jaw to chew food, to swallow. So it's the grinding and clenching that goes on. And the interesting thing about that we're finding out that more and more research is being done now is the idea that there may be a link between this grinding and clenching that's more about keeping some tone in the muscles to maintain the airway.
Right.
So you see that linked a lot of times with people that have obstructive sleep apnea, also grind and clench their teeth. And so for dentists, it's important for them to determine not just that somebody's grinding and clenching their teeth, but maybe why that's occurring.
Why that's occurring, right. And if it occurs over the long run, then we sometimes get temporal mandibular joint pain and dysfunction.
And headaches, all kinds of other painful.
So if a person is having popping and clicking in the temporal mandibular joint, then that's not normal.
Not normal, right.
Not normal.
Right.
We need to evaluate that and to do something, because over the long run, my understanding is that in essence it can become a form of arthritis.
It can, but most of the time we don't see the popping and clicking. What we see in patients more is morning type headaches, like every morning, a lot of head and face just pain, deep pain, issues, and
not necessarily confined.
Not confined just to the joint.
Okay, all right, very good. Well, I think it's very apparent that this is an active and evolving area, and I think Dr. Aguilar would agree with me that, again, the inclusion of dental sleep medicine into the field of sleep medicine has been a huge advance. And this is fairly recent. I would say last 10 years maybe?
Well, actually,
10, 15 years?
25 years or so.
Okay.
Between 25 and 30 years. I was really kind of the first in this area to do this on a larger scale about 12 years ago. So.
Well, it's I think an exciting future as well. So, well, I'd like to thank each of you for being our guests today. We've been focusing on the area of dental sleep medicine. As always, we want to emphasize that if you are concerned about your sleep or the sleep of a loved one, please reach out to your primary care provider or a sleep medicine specialist or dental sleep medicine specialist for help. The areas of sleep dysfunction are so important that they really need to be evaluated, and we want to encourage you to seek help. Thank you for watching. This has been The Power of Sleep. I'm Dr. Merrill Wise.
WYPL TV 18 was proud to present The Power of Sleep, sponsored by Methodist Sleep Disorder Center, dedicated to alleviating the effects of sleep disorders and improving the sleeping lives of our patients. The Methodist Sleep Disorder Center can help you determine if you may have a sleep-related breathing disorder. If you believe you or your loved one may have a sleep disorder, consult your physician. More information from the Methodist Sleep Disorder Center can be found online at www.methodisthealth.org/sleep or at 901-683-0044 to determine your best treatment option. Methodist Healthcare. Be treated well.